International Society. So I want to welcome everyone, including our distinguished panelists and all of our participants who are joining us to really learn about the science behind Lecanemab, also Lecanemab, and what's going on with its approval at the FDA. So just a little bit about Alzheimer's International. We're a nonprofit organization. Our goal is to facilitate and accelerate both research and prevention for the treatment of Alzheimer's disease. We provide services and support to stakeholders around the world. And it's my pleasure to introduce Les Hamasaki. Les, there you are, who's our executive director, and he's going to share a little bit of his personal story around his experience with Alzheimer's. And Les, I'm going to turn it over to you, and welcome to you and to everyone, including our panelists. And I'm going to get out of the picture.
Good morning. I am the Executive Director of the Alzheimer's International Society. My name is Les Hamasaki, and I am 84 years old. Watch the people you love lose their memory is a different type of pain. I had firsthand experience seeing someone I feel admired lose to their disease. As an executive director, I carry the memories that my friend couldn't. I experienced the struggle of having someone you deeply care about suddenly forget everything, including me. I do not want you to pay your pain or sympathy. However, I feel that it is my purpose to spread awareness. I want to say thank you from the bottom of my heart for your attendance and participation. Thank you.
Thank you very much, Les. Can all the panelists hear me? Okay.
Sure.
Well, first of all, I want to thank everybody for participating. You know, it's obviously it's a very important issue for all of us. So what we're trying to focus on is the upcoming FDA full approval of Lecanemab. You know, we rushed to put this together in anticipation of the July 7th, I guess, a deadline that the FDA said they would make their announcement by. And so, you know, apologies for really quickly organizing this. There'll be many glitches, who knows, but hopefully it'll go very well. The audience is very large given the short time frame. As of this morning, we had over 250 registered attendees. So whatever you guys say, you'll get a wide audience, right? Maybe good, bad, who knows? But nevertheless, you're not just speaking to a few people in a dark auditorium. So with that, I'd like to start the program. We have a short time frame. You know, the total time is 90 minutes. Actually, it is now 84 minutes. So if you would try to be brief, especially with your introduction, you know, I've scheduled about 10 minutes each for your presentation, and you can certainly have slides if you need them. There's on the bottom part, it says share screen, and then that'll allow you to, you know, pop your slide up and so on. So with that, what I'd like to do is to call on each one of you to make a very brief introduction, just say a few things about yourself. I know that from looking at your brief bio sketches that you're all very distinguished and accomplished people. And so I feel honored to be in such good company. All right, so Dr. Zuckerman, would you start off with just a minute or two introducing yourself?
Sure. Thank you so much. I'm very glad to be here. I'm Dr. Diana Zuckerman. I'm president of the National Center for Health Research in Washington, D.C. We're a small think tank that works on public health issues and especially on the safety and effectiveness of medical products. My training is in epidemiology and public health, and I also, so I was a researcher at Harvard, on the faculty at Yale, and also worked in the US House of Representatives, the US Senate, the White House, and the US Department of Health and Human Services. And I've been head of the National Center for Health Research since 1999. Thanks for inviting me.
Okay, thank you very much. Professor Perry?
Yes, I'm honored to be part of this discussion. It's a topic I've had a lot of interest in for years. I guess relevant to this discussion. I'm editor-in-chief of the Journal of Alzheimer's Disease and been an Alzheimer's researcher for 40 years. And have questioned the amyloid theory for the last 20-some years, together with Mark Smith and also in some cases with Dr. Castellani. And more recently with Paul, actually, also joining the cause.
Dr. Hoyland Carson?
Yes, I'm a professor of clinical physiology and have been in charge of a large department of nuclear medicine in Odense, Denmark, where we have the biggest hospital in Denmark. And I am really a newcomer in, if I could say that, in brain research. I've only really gone in depth with that for 5 years. Otherwise, my specialty is doing a lot of different examinations, but mainly now PET in a variety of serious diseases, including brain diseases. So my specialty is, so to speak, PET, and that's what I'm going to speak about in this connection with Alzheimer's disease.
And Dr. Castellani?
Yes, hi, I'm honored to be here as well. My name is Rudy Castellani. I'm a neuropathologist. I've worked with Dean Perry over the years on Alzheimer's disease. I'm currently the core director for the Alzheimer's Disease Research Center and Meslin Center for Cognitive Neurology at Northwestern University. I've recently seen one case of Lecanemab related death, and another one that was reported in the literature with very similar pathology. So those are anecdotal accounts, but I think they offer tremendous insight into some of the mechanisms of toxicity and mechanisms of clearance of A beta. I have no conflicts of interest, and I look forward to the discussion.
Great, thank you. Finally, myself, just again, a quick, brief introduction. I have been a professor of biostatistics and informatics at the University of Colorado School of Public Health for over 30 years. I'm also a professor of pediatrics at the University of Colorado School of Medicine for about the same amount of time. My specialty has been, while I was a professor, in meta-analysis and the design and analysis of clinical trials. I've done, drug trials as well as trials utilizing device. So as a biostatistician, my interest in Alzheimer's is looking at data, looking at the numbers carefully. Perhaps some numbers that people skim over or not pay attention to that are interesting. So hopefully, given adequate time at the end of all our presentations, I'll be able to provide you with some numbers to think about. Numbers are interesting to me, and it's been my whole life, and I just, enjoy numbers. My official capacity here is as a volunteer for the Alzheimer's International Society. And I think Les owes me at least a cup of coffee because prior to this time, I have not received any compensation. Having said that, why don't we get started with our program? We're actually running a little bit early, believe it or not. So let's keep it that way. All right, so let's start off with Dr. Zuckerman.
Thank you very much. I see my slides are up and somebody's taking care of them, so I don't have to. Great, perfect. So disclosures, the National Center for Health Research is a nonprofit think tank that focuses on the safety and effectiveness of medical products, and we do not accept funding from companies that make those products, so I have no conflicts of interest. Next slide, please. Oh, I guess I should have said as a conflict of interest, my father did have dementia, and so that does, of course, influence my views on what's needed and what has not been available to patients. So let's, oh, I'm sorry. Yeah, go back. So the FDA standards for the full approval, which is what they're considering for lecanemab, the standards are that the evidence must be that the benefits likely outweigh the risks, and the benefits should be clinically meaningful, and the study population should be relevant to the indication that it's approved for. Remember, when FDA approves a drug, it's for a specific indication. But that study population doesn't have to be diverse. It doesn't really have to be representative of the US population or of any particular group. And it does not need to be over the age of 65. So that's obviously relevant to Medicare coverage. I just want to mention that this is for full approval. What the Aduhelm as well as lecanemab currently have are accelerated approval, and the standards are considerably lower, and they're based primarily on surrogate endpoints, also called biomarkers. And in this case, it was both based on the drug's impact on reducing amyloid plaque in the brain. Next slide, please. So the summary of efficacy, according to the New England Journal of Medicine and the data that was presented to the FDA at their recent advisory committee meeting, was that there were statistically significant differences, not showing improvement, but showing less impairment over time, over 18 months, on several cognitive outcome measures. And the FDA review looked at these impaired scores, cognitive scores specifically, and said they were clinically meaningful because they were statistically significant. But I think many of us know that significance in terms of statistical significance does not mean that something is clinically meaningful. The differences were very small, and the FDA did not point out something that I think is especially important, which is that mild cognitive impairment fluctuates over time due to social interactions, depression, and other factors that have nothing to do with medication. Also, they do fluctuate because people take allergy pills, sometimes they take painkillers, sometimes they take anti-anxiety medication, and all of these things can impair cognitive function to a degree. And so when we look at something that a drug that might possibly have a small impact on mild cognitive impairment, we have to realize that there are many other ways to modify and reduce mild cognitive impairment. Next slide, please. I don't have to go through this because I know that the scientists coming after me will go through this in some depth, but the FDA acknowledged that there were known risks. They acknowledged that there were certain risk factors that would make some people more likely to be harmed by lecanemab. And also, they did point out that 22% of the patients in the study who were on lecanemab discontinued participation in the study compared to only 17% that were on placebo. Remember, people discontinue for different reasons. Sometimes they discontinue because they feel like they're getting worse. Sometimes they discontinue because of bad side effects. And sometimes they discontinue because, in this case, they don't like the infusion. Next slide, please. There was a certain lack of diversity. Only 2.3% of the patients taking lecanemab in the trial were Black, and that was only 20 patients. Obviously not enough to say anything about those patients. There were 17% that were Asian, and that sounds like a lot, but almost 16.5% of those were being studied in Asia. They were living in Asia. They were not Asian Americans, and so they might be different from Asian Americans in terms of the impact of these of this medication. And other racial diversity totaled only about the same number as Blacks, about 20 people. There were a fair number of Hispanics in the trial. Next slide, please. So just to say that part of the big controversy now is whether Medicare should be paying for Lecanemab, even if it does get full approval. And the standards for Medicare payment are different from the standards for FDA approval. The benefits must outweigh the risk, not just for whoever was being studied, but for the Medicare population. And so that would be people over the age of 65 and people with disabilities, because there are quite a few Medicare beneficiaries who have chronic disabilities, and that's why they're on Medicare. And I just want to say that the FDA Commissioner, Rob Califf, has publicly stated just at a conference for bio on June 7th, that the standards are different and it's okay for those standards to be different. And this is what he said: FDA, safe and effective. CMS, reasonable and necessary. It's like a relay race we run a lap and then pass the baton to CMS. CMS doesn't tell us, meaning FDA, what's safe and effective, and we can't tell CMS what's reasonable and necessary. So these are very different standards, and that makes CMS an important gatekeeper to make sure that they're paying for drugs that are not just safe and effective and not just having a meaningful benefit, but they must have a meaningful benefit for the kinds of people who are Medicare beneficiaries. And I think that's my last slide. Thank you very much. So I hope I have set the stage of what these kind of controversial policy issues are in the United States. I hope we'll hear more about what's going on in other countries as well, but I'm leaving it to the scientists to talk about who are experts in Alzheimer's, which is not my expertise, although I've done publications on it and worked on these issues, but to hear from them what the science is telling us. Thank you very much.
Thank you, Dr. Zuckerman. I think you did a very nice job of setting the context for the rest of the talks in terms of the policy and what has led us to the July 7th deadline. So, Professor Perry, you're up next.
Yeah, so Alzheimer's disease, has been known for over a century with the description of Alzheimer's of plaques and tangles and a dementing illness. And that's been the focus over this past century plus, is these changes that occur in the brain, and more recently, in the last 30 or more years, removing these changes because they're always associated by definition with what the disease is. And that's where I think the problem has begun and continued, is these are associations, and people have taken those ideas and an association and said, well, if we remove the plaques and tangles, that the disease will be reversed. And over 25 years ago, Mark Smith and myself started noticing in cell culture studies that amyloid was not always toxic. It depended on how things were presented. And then subsequently, when we were doing oxidative stress studies, which really comprised a major focus of our research for the last 3 decades, we noticed that amyloid was associated with a reduction in oxidative stress. And based on that, we came to the question, the amyloid hypothesis, which was developed over a similar time period. not questioning it as amyloid being irrelevant, but the amyloid not being causality. And the main evidence for that causality is genetics, that mutations related to amyloid and amyloid processing proteins are associated with autosomal dominant Alzheimer's disease. But there's a big misunderstanding there of causality. And the best test of causality is not the genetics, which is an association, statistical association, which Dr. Tran, you're aware, statistics mainly just shows association, doesn't show something as causative. And the best causative thing is that removing the amyloid from humans reverses the disease. And what we have with lecanemab and Aduhelm and all of the other vaccines, over 20 of them, is not a reversal of disease. What we see at best is a slight change in the last couple trials of a slight change in decline. That significance of that has been questioned. There's a blog at the Journal of Alzheimer's Disease that people can comment on, written by one of our authors. And the change is not 27%. It's actually below 10%, depending on how you calculate it, 2 to 10, 8, 9%. And whether that's clinically significant is very questionable. Certainly, prior estimates are that you couldn't even distinguish this to be anything. And back to the other, I think the big problem is the amyloid hypothesis is based on a really misconception of biology. I say a misconception that's below what I teach in freshman biology. And that is that I would actually question whether 18-year-olds couldn't spot this issue. That is that the biology of common responses in well-adapted species have biological significance. Amyloid is a response to injury, much like inflammation is. And you have all these inflammatory molecules being produced during damage. And are they good or bad? Well, it depends on context. But the amyloid cascade hypothesis and the treatment based on it assumes it is always bad, and therefore removal will have only benefit. We haven't seen that. In fact, of those 20 trials, almost all of them, the patients got worse. In the case of lecanemab, we're going to talk, Dr. Castellani will talk about that index case that he performed the autopsy on, but we really don't know how many people are involved. 20 years ago, Craig Atwood, Mark Smith, and myself wrote that one of the outcomes of treating patients to remove amyloid would be cerebral hemorrhage. Why? Because the vessels very often are replaced. The wall is replaced by amyloid. The muscles are dead. And when you remove the amyloid, there'd be no vessel integrity. That doesn't deal with the issue that you destroy oxidative balance and other things. Certainly, what was promised from the amyloid cascade hypothesis was a cure. Changing the slope less than 10% would still decline is not that. Okay. Further, every time this hypothesis is shown to be failed, as Dr. Castellani, together with Smith, wrote, the theory changes and becomes totally untestable. And where it should have been the most clear was when the people that have autosomal dominant disease. And that's been done already a couple times, and none of those patients improved. In fact, again, there was a slight decrement, which is, again, what we predict based on amyloid being a biological response. And I thank you for being able to present just that summary of some aspects of our questioning of amyloid.
Thank you very much, Professor Perry. It's very informative. Next, let's see, Professor Holland Carlson.
Yeah, I'll see if I can open my slide presentation and make it work. Can you see something?
No.
Not yet.
How do I get that? Well,
at the bottom of your screen, there should be a green arrow that.
Yes, I pushed that. I may push the share button also. What about now?
Yes, we can see your screen now.
Wait a second. Now?
Yes, perfect. Thank you.
It's okay. Okay. I entered into this discussion, so to speak, a few years ago when I started looking at the images. And these are amyloid PET images of patients. And those are really from the only two trials which have published images. Otherwise, you only see declining curves showing a decline of amyloid deposits during treatment. But if you look, this is from a 2019 study of gantenerumab. If you look here at these 5 different patients, some of them, nothing is really happening with time. And in some of them, something is happening. The only thing is, it's not in the gray substance. It's in the white matter where the disease isn't located at this time point, provided it is a matter of amyloid deposits. In a brain like this, the width of the brain is about 14 centimeters, 140 millimeters. The gray matter brim is 3 millimeters. So alone from this, you can see something, this kind of documentation doesn't really show anything. This is from the Nature study by Sevigny et al. About Lecanemab, and this is really the basis for FDA's first approval in June 21. This is what they think is the main reason for making the approval: removal of amyloid from the brain. It's only from the white substance and not the gray substance, even if the authors declare otherwise. Then I started really going through all the literature of these trials. And now I turn to the Lecanemab study by Van Dijk et al. And here you have one of the many cognitive scales. In all these trials, maybe 15, 20 trials, they used about 25 different cognitive or functional scales. And there's absolutely no standardization. This is the so-called CDR-SB scale with a range from 8 to 18, and impairment is in this direction from left to right. And here you have the placebo patients. In 18 months, there was a deterioration of 1.66 point on this entire scale against one with lecanemab of 1.21. And sorry. Oh, wait a second. The difference is this one. There's a difference only 0.5 points out of the original 1.66 in the placebo patient. And that's what they call in press releases a 27% slowing of cognitive decline. So let's look at the scale. If there had been an improvement, you should have a change in the green direction, but that's not the case. You have this small change, which is only 2.5% of the scale range. Or when you go to the literature, and there is now new recent literature of this showing that this is about what is only 30% of what is considered clinically meaningful. And I have been through all trials, and I can show you that not a single one of the statistical significant differences are larger what you can achieve with conventional therapy. So we started looking a little bit more on brain imaging. And in all these studies, really uptake of an amyloid tracer, and this is the first one which was developed, 11C Pittsburgh substance B. If it was really an entry criterion, you should have amyloid positive patients. And this is an image of an AD patient with PEP scan. And you can readily see that that's much more uptake than in the 3 millimeter thick gray substance. Here you have FDG uptake in the same patient, and the ratio between uptake In the gray and the white patient with FDG is 5:1. With PIP, it's 1:1. So there's a lot of volume here, which is taking up the amyloid tracer, which is the entry criterion. This is what you measure during treatment. Here you have a template of what we would say, this is the area for the FDG uptake. And if you superimpose that on the PIP image, you can see there's a lot of uptake outside, or in fact, inside the uptake in the gray matter, meaning that you have a lot of non-specific uptake in tissues, which at this time point is almost devoid of amyloid. But to put it another way, we will say that you can't use really amyloid imaging for this purpose. Here you have FDG uptake, and that is really the only method to study metabolism in the brain, which is a mirror of neuronal function. In patients with MCI, you can see you have decreased uptake, typically here in the frontal parietal region, and it's going to be even worse in patients with AD. We can technically reverse the uptake here to show where you should have increased uptake with amyloid traces in case they're really mirroring amyloid uptake. But that's not the case. Here you have actual images with another amyloid tracer, and there's not an increased uptake in the temporal parietal region, but there is an increased uptake in the frontal region. So it doesn't fit together. So I have here summarized really from the clinical phase 2 and 3 trials of the most common or most popular recent studies, Lecanemab, and Lecanemab. And here you see what they claim they have registered of amyloid change in these. Large decreases in amyloid change compared to what has been seen with MRI, the so-called amyloid-related imaging abnormalities with edema type or with hemorrhages. And the bold images show the much higher frequencies than in placebo patients. The strange thing is, all these studies used MRI to monitor ARIAs. And they even think if the MRI signal decreases, nothing has really happened. But they don't know because MRI cannot mirror brain function. Data was really there for showing also measuring what happened to the brain volume, but they didn't give the data. 3 of them did. And in these 3 studies, there was a reduction in whole brain volume or in hippocampal volume or in ventricular volume, there was an increase. So if I should conclude, I would say clinical effects are rare, small, and of similar size, and even smaller than with conventional therapy. My personal meaning is that I don't think there is a significance. We can discuss that later. The presumed removal is, in my view, and my tutor's view, that is about Alavi, is what we see is much more liking a decreasing PET signal. Why? Because there is an increased damage to the brain tissue, which means that cannot take up the PET amyloid tracer anymore, and that it's much more consistent with the ARIAs we see, the increase in ARIAs, and the loss of brain volume, which is also increased by at least 30 to 50% in those trials where they measure it. So we recommend the only way to show what really happens in the brain is to use FDG PET. That's the only existing method for the time being to show what happens with brain function. And add to this MRI, not only to detect ARIAs, but to measure brain volume loss in all upcoming trials. Thank you.
Thank you very much. That was very informative. And Next, I would like to call on Professor Castellani.
Thank you. I don't have a formal presentation. I suppose I could pull up a paper if you like, but let me just go through. So the anti-amyloid therapies have been in clinical trials now for more than 20 years. The first one was in around 2000, I think, when it was started, AN 1792. That was an actual vaccine. And the results were similar to what we're seeing now. There seemed to be a decrease in the amyloid, and the clinical benefits seemed to be nil. And it was associated with toxicity. At that time, I think 6% had a meningoencephalitis. So if a few years elapsed, and now we have these anti-amyloid antibodies that are being administered intravenously. And it was known pretty clearly early on that their brains would light up on an MRI scan with signal abnormalities, depending on whatever different image acquisition sequences. But clear signal abnormalities, and sometimes associated with symptoms. And a working group met, and that was given an acronym: amyloid-related imaging abnormalities, or ARIA, which it sounds like it was kind of portrayed as this evanescent change that's purely imaging, and if you wait enough time, it'll go away. Although some people had more severe examples of it, and it was not really elucidated in terms of the pathological substrate. In other words, if somebody has something on imaging, what's the pathology behind it? That's something I deal with every day with neuro-oncology, and it's not that straightforward. And I've always found it interesting that ARIA has been around for nearly 15 years, and we still have no clue as to what the pathological substrate of that ARIA is. And the old trial also, we know that, again, the brain apparently shrunk with these treatment as well. So, one could speculate as to why that's the case. And so last September, there was a case that came through our emergency room. It was an individual who was actually quite healthy and living independently. She was out sailing with her husband the weekend before. She was out looking at real estate with her children. So very functional. She was participated in a clinical trial for Lecanemab for a period of years. We don't know whether she was on drug or placebo. That trial concluded, and then she was granted access to Lecanemab through the open label extension phase. She received 3 infusions, and over about a month, a couple of days after her last infusion, she started having neurological symptoms, such as speech arrest and other signs. And she presented to the emergency room very quickly. It's actually a highly educated individual, highly compliant individual, actually very excited about the research being done in Alzheimer's disease and these new drugs. That's in fact why she participated. She happened to be an ApoE4 homozygote. She was at a genetic risk. So at any rate, she presented the emergency room very quickly, and the neurologist then had to weigh, is this a stroke? And if it is, and should she be given therapeutic intervention with TPA, tissue plasminogen activator? And the decision was made to give TPA because it's standard of care for stroke if you come in early enough and you meet certain criteria. And within minutes, she bled into her brain and became agitated. When I say agitated, that's kind of a euphemism. She required restraint of all 4 of her extremities, writhing in pain, had to be sedated, and she existed on cardiac life support for a few days and died. So it was a very unfortunate scene that probably doesn't get its full due in the various reports that are out there on this. And basically what we found in the autopsy was a attack on a histiocytic attack on amyloid. And the histiocytic attack involved amyloid plaques, as expected, as is touted, but it also involved his histiocytic attack on blood vessels that had a lot of amyloid angiopathy in them. And that amyloid attack on the blood vessels led to destruction of those blood vessels and what we call necrotizing vasculitis. So the hemorrhage in this case was not a mystery. If you looked in the brain, there was in the cortical vessels where there was amyloid, there's basically very little left in many of these blood vessels except some proteinaceous material that's keeping the blood vessel together, i.e. fibrin, which is a substrate for TPA. And so clearly she bled for that reason. So what we learned from this case is that, well, number one, ARIA is probably a macrophage or histiocytic attack on amyloid, and not just in the parenchyma or the plaques, but also the blood vessels. And we also know that the clearance of this amyloid involves a destructive process. There's a lot of talk about perivascular clearance or the amyloid being removed in some sort of soluble phase through the lymphatics and so forth. That does not appear to be the case. Or if it is the case, it doesn't seem to be significant. What is significant is really the histiocytic attack on amyloid and the tissue destruction associated with it. So those were the take homes from this, that we have clear evidence of toxicity, clear evidence of how the amyloid is cleared, and both of them are kind of underappreciated. It also is pretty clear that this drug attacks or binds to insoluble amyloid. And the construct of the drug, we were told that it binds to soluble protofibrils. That may be the case in vivo, but clearly we can't tell pathologically whether something is soluble or not. But we can certainly tell that insoluble amyloid is being attacked and destroyed and carried away. So those were the major ones. One thing that I think the group should be aware of is that cerebral amyloid angiopathy is quite variable from person to person and case to case. Some Alzheimer patients have very little or none, and some have quite a lot. And even if they have a lot, it may not be clear on imaging that they have a lot of amyloid angiopathy. It's a roll of the dice, basically. So in our case, because the vascular pathology was really what led to the death, I think that one has to be very sensitive to the idea that we really don't know how much amyloid is present in the blood vessels of a given patient, and therefore we can't predict toxicity in any given patient, or whether or not something would be lethal, like the case that we saw. So that's kind of long and short of it. So in terms of safe and effective, and again, these I should say that these are just my opinions I'm talking about now. Is it safe? I don't know. It was lethal in our case, and there's another case where it's lethal. So I don't know if you could make the case that it's safe. Is it effective? The efficacy is said to be a reduction in the rate of decline that can't be sensed by any individual patient or their family, and maybe a statistical artifact we don't know yet. So I don't know if you can say that's effective or reasonable and necessary. I don't know how to answer that. And I think that's those are the major points that I wanted to make there, and I'll be happy to answer any questions. I think you're on mute there.
Sorry. Even the moderator makes mistakes. So anyway, that was a very informative discussion, presentation there, Professor Castellani. I guess I'm up now, so I'll try to make my presentation brief and just kind of to the point, using the numbers from previously published trials on Lecanemab. So obviously one of the trials is the phase 3 trial, but the FDA based a lot of what they reviewed on the phase 2B trial. So let's take a quick look at some of the numbers. I know Some of you in your presentation have alluded to the numbers. Let's see, share screen. There you go. Now I should put it on full screen, right? All right, so the first presentation, hold on a second, let me put the timer on myself. Okay. The first publication I'm going to look at is the most recent one by Van Dyke et al. It's Lecanemab in early Alzheimer's disease, published in New England Journal of Medicine. Its official publication date was 2023, but it was actually published online at the end of 2022. So very briefly, it was an 18-month multi-center double-blind phase 3 trial. The total sample size was 1,795 that was randomized on a one-to-one basis, where 898 to the Lecanemab group and 897 to the placebo group. The dosing was by IV, biweekly, every 2 weeks, 10 milligrams per kilogram. And they use a PET scan and a measure of cerebral spinal fluid also to determine amyloid. So their primary endpoint was the so-called CDR-SB. This has been already mentioned also, that the scale goes from 0 to 18, with higher indicating worse. So this is the plot or the graph that's sort of like the basis for the claims that this is the Lecanemab line, this is the placebo line at the end of 18 months. Notice that it's a change scale, so it goes from 0 to 2 and not 0 to 18. So I guess I could say now that this is what I know in beginning statistics class. I used to tell my students, this is a gee whiz scale. So you can make anything look like, ooh, gee whiz, you know, based on how you plot the evidence or plot the data. All right, so just to kind of summarize, again, this was recently mentioned just now. The Lecanemab, because it's randomized, you know, the baseline is going to be very similar, right? So basically 3.2 goes, increases to 4.41, keeping in mind that the higher the score, the worse the patient outcome. Placebo went from approximately 3.2 to 4.86. So this increase was 1.21, and this increase in the placebo group was 1.65. All right, so the difference then is 0.45, right? So this is the kind of the difference on that you just saw on the scale, the gee whiz scale. All right, I'll show you again. So this is 0.45. All right, remember again that this is a scale that goes from 0 to 18. All right, so this 0.45 difference is often interpreted by, well, in the journal itself, as well as in the media, press releases, et cetera, as a 27% less cognitive decline based on this calculation in favor of Lecanemab. In other words, there's a benefit in favor of Lecanemab. But notice that they both got worse, right? So I call it a less worse scenario. Not that anyone got any better, but they just got less worse over time compared to the placebo. Well, where does this denominator come from? 1.65, right? And in fact, is it the correct denominator? And I think one of the professors had mentioned that, no, that's kind of a strange denominator to use. So what is the correct denominator? Well, you know, this was the endpoint for the placebo group, right? After 18 months, the score was 4.86. 4.86. In the Lecanemab group, it was 4.41, which was a difference of 0.45. So the actual division should be 0.45 divided by 4.86, which gives you 9.3%, right? Which is very different from the claimed 27%. So, I won't call it a statistical sleight of hand, but I think it's the way you want to make the calculations and how you want to interpret. I'm a statistician. I believe in truth, and this is kind of not so true. As indicated, even the 27%, what you want to do is to go with the raw score. This is a scale where it's dependent on a caregiver, physician, to examine the patient and make a determination on 6 factors, right? And then each factor gets a score of 0 to 3, where 0 meaning no impairment, 3 meaning very impaired. So, as a clinician, can you say that a difference in a patient of 0.45, is there a material difference? In other words, is there any clinical change or benefit? Well, let's take a quick look at the results using the full range, right? So I took the liberty to make a plot using the full range.
Yeah.
And you can see that the 2 lines almost overlap, right? So this is the 0.45 difference. So this is the way the scale should actually look like, right? Going up means worse. They both go up, and they're almost superimposable one on the other. So that's the evidence. Now let's quickly look at the phase 2B trial. This is published by Swanson et al. In 2021. It's also an 18-month multi-center double-blind phase 2B trial. Sample size smaller, 854, distributed in this particular manner. Same kind of procedure every 2 weeks, 10 milligrams. The big difference here is that they were testing several different doses, starting with 2.5 milligrams per kilogram and went all the way to 10 milligrams per kilogram. And notice that it was the highest dose that was picked for the phase 3 trial, thinking that it would be the one that would show, potentially show most benefit in the phase 3. Here again, just take a quick look. Remember in the phase 3 the average was 3.2. This is 3.0. Went up to 4.1, an increase of 1.1, 3.0 to 4.5, an increase of 1.5, or the difference of 0.4. Notice that it's 0.4 in the phase 2B trial and 0.45 in the phase 3. So not much, right? Not much difference. Now, this was the plot that was in the publication, okay? And so the green line was the Lecanemab at 10 milligrams per kilogram body weight, and this was the line of the placebo. Well, can you see if you take out the middle line, that was another dose, it looks very remarkably alike in terms of the phase 3 trial. I didn't take the time to manipulate the graphs and superimpose one on the other, but the pattern of change is almost exactly the same. And of course, we know that this is a 0.4 instead of 0.45. So this was considered not statistically significant at p equals 0.05 or less than 0.05, right? But in the phase 3 trial, really the same effect size was statistically significant, p equals less than 0.05. It was point something, p equals point something something, I can't quite remember. But it's in the publication, so you can look it up. So this is the phase 3 trial, right? Pattern of decline or less worsening is the same. All right, so here's the thing that I want to kind of talk about that. I don't think anybody else has in terms of these two publications and the comparison between the phase 2B and the phase 3. And that is the effect size. So this was actually calculated. You would find these values in the phase 3 publication by Van Dyke et al. Right? It's embedded in the methods selection, statistical methodology. So what they did was they actually took the results of the phase 2B to calculate the appropriate sample size for the phase 3. All right, so this was the difference between the lecanemab and placebo. The difference, right? It was 0.37, so I said 0.4. Excuse me for a second. I'm actually the only person who's gone over time, but if you bear with me a couple more minutes. Let's see. All right, that's my train of thought. I said 0.4, but it was actually 0.373. That was what they found in the phase 2B trial, right? The standard deviation of that change, again, from the phase 2B trial was 2.031. So the effect size, the standardized effect size in standard deviation units is that ratio, right? I think I mistyped it, but heck, I'm off by a few hundreds here, no big deal. The effect size is 0.184, right? So keep that in mind, that's a very small effect size. Effect sizes below 2 are considered extremely small. 3 to 0.5 is moderate, 5 is to 0.7 is large, and so on and so forth, right? So there's a kind of a pseudo scale associated in terms of adjectives describing size of effect. So this is a small effect size, all right? So you start off from there, and this effect size was significant, p less than 0.05 in phase 3, but it wasn't in phase 2B. So the question then is why? Well, I think most of you would know, and if not, quick refresher, statistical significance is very much driven by sample size. So you can give me any samples, any effect size, no matter how small. If you can give me an effect size of 0.1 or 0.01, and I'll tell you what size sample would be necessary to deem that difference or that effect statistically significant, right? Because you're kind of working backwards. Right, so I did a plot just to show everyone what in reality, what's going on, right? So the sample size for the phase 2B was around, what is that? It was 800 something. So let's call it 900. So you look across there and P value is 0.15, right? Not significant at the 0.05 level. But if you have a sample size of 1,700 or something like that, guess where you are? It's going to be statistically significant, right? So sample size is driven by the effect size, the power, and the alpha, right? And so with any effect size, you can get statistical significance if you have a large enough sample size. And that was the big difference, because remember, the effect was the same, 0.4 versus 0.45 in terms of the CDR-SB score. So I'll leave that and get back to some questions. Hey, Michael, how do I get out of the share screen? Click it on again? Yeah. Okay. So, can everyone hear me?
Yes. Yeah.
I'm back live. All right. So, I hope you found that a little bit informative. I know it's a lot of, I made it very quickly. And as I said, unfortunately, the moderator was the only fellow who went over time by a few minutes, but because all of you went under time, we were okay on time. So the next thing I want to do is to do some questions. I had sent all of you a list of questions. I assume you all got it, right? List of questions? Yes? No?
Yes.
Yes. So I'm not sure exactly what the most efficient way would be. I don't know whether if you have seen it, are there some specific questions that you would like to field yourself? Or should I just start down the list and say who would like to answer these questions? Which way would you want to do it? Or we can combine the two ways. You know, if there's some specific questions that you feel that you would like to answer, then that would be fine. But you know, I'd like to also make a couple of things just from listening to all of you. And I'll take the moderator's prerogative here. Professor Perry.
Yes.
I really understand what you're trying to say. I think you were talking about correlation or association is not causation. And I think that's a very important factor when people are either reading research or doing research, because when it comes to the amyloid plaque, amyloid beta buildup, et you know, is it the disease that causes the plaques or the plaques that causes the disease? And that's a major distinction, you know, because if you can't even, you have to be able to establish the directionality of the correlation, right? Because if you don't do that, you cannot have causality. I mean, it's just, that's the end of the story. So I just want to comment on that very quickly. And Professor Poland Carlson, a quick question for you. You know, when you have a measuring technique, when we test the reliability, one of the aspects of reliability is test-retest reliability, right? And so with the reliability of scans, how reliable are they? I mean, how reproducible are they in terms of test-retest reliability?
Should George start answering or should I?
Oh, you should, yes.
Okay.
I was opposed to you, sorry.
Well, that depends on what you mean by reliability. Mm-hmm. In my view, for diagnostic tests, you have to make accuracy, meaning that you're really measuring what you should measure. You should make that probable before you try to estimate retest or retest variation. And in my view, you cannot do that with very much brain research because there is no infallible reference. I have written about it many times. The only there is really is what Rudy Castellani does, but there is often a time lag between the period when you do, for instance, a PET scan until the patient at some time point dies. So there's a very big difference also biologically between the in vivo situation and the post-mortem situation. Mm. So in my world, you cannot prove that you're really showing what you should show. Yeah. When it comes to reliability, the reliability or the retest or I call it precision, can you get the same number if you measure amyloid in the brain, if you redo the scan once again? The question is, that's very, very difficult for several regions because the brain has different sizes, and unless you use the same scanner, the same tracer, on the same time of the day, the same observer, you will have a very big variation. And beside that, you have the biological variation, which none of us know. And there hasn't been any satisfactory examinations of that, to my knowledge, when it comes to amyloid brain imaging.
Right. And that was I was getting at.
Besides that, there is a question of accuracy, and that's a matter of whether the tracer targets what it should be, what it should target, and it doesn't. It has been neglected all the time from the 2004 first publication. It hasn't been examined properly. On the contrary, there's uptake with information without amyloid. There's a lot of these, and you see the uptake in the white matter, where there's even more uptake if there is myelin damage. So you have an inaccurate tracer with a questionable reproducibility.
So to make a major decision based on scans is questionable.
My personal opinion is it's a useless scanner tracer. Whereas PET is a beautiful technique, it's just the wrong tracer.
All right, so on to the questions. How would you like to do that? Is some of you will really want to answer some of that question? That'd be fine.
Yeah,
Dr. Zuckerman, go ahead.
Yeah, I'd like to address one of the questions that has been asked, and that is, what's the difference between statistical significance and clinically meaningful? Because that's such an important question here.
Yes,
the FDA is well aware, as I think all of us on this panel are, that statistical significance means a difference is unlikely to have happened by chance. Unlikely means that there's only about a 5% chance that it happened by chance. Clinically meaningful means that it's a difference that's large enough to mean something to the patient, to their families, that it didn't, that it isn't just something that, might vary from day to day, but doesn't, really mean anything. So when the FDA had this past meeting, and the advisory committee all did recommend full approval for Lecanemab, the FDA stated in their written and oral statement that they felt that anything that was statistically significant in this case was clinically meaningful. And that is just, I had to read that like 4 times because I couldn't believe they had actually said it. And for those of you in the audience who aren't very knowledgeable about statistics, as has been stated today, the larger the sample, the more likely that something will be statistically significant. And it can be a very, very tiny difference. It doesn't really mean anything. So when patients and doctors are thinking about whether this drug is worth taking the risks that we've talked about, you have to think about whether this benefit of slightly less, maybe slightly less cognitive deterioration is worth the risk. And that's, to me, that's the big issue here.
Yes, go ahead.
One of the things I learned from Dr. Tran is, prior to this, I said, for these drugs to be effective, you would need to have 1,000 mothers. Now I know you need to have 1,700 mothers in order to see the effect.
Yep.
In other words, it's not meaningful in a real life situation where you have only one mother, one father, or one spouse. You're unlikely to see any benefit.
Yeah, statistical, the word significance attached to statistics probably isn't the best choice, because what you're trying to do is you're testing to see whether an observed difference, say, is different from 0, right? Which does not imply that it is significant in the way that we tend to use the word significant. It's a probability of it not being a non-zero difference.
Yeah, it's like saying winning the lottery. Somebody will win the lottery, but it's unlikely to be you.
That's correct.
May I add?
Go ahead.
I think I have looked upon the changes in trials with all 8 passive immunotherapy drugs. And the changes which have been reported in none of these scales has it's been larger than 3% of the entire scale range. None of them. And none of them have shown any, even if it was statistically significant, which was close to what is considered the minimal important difference. And as I'm a semi-cardiologist, and I would say, if you can't show a difference, a clinical difference, in 100 patients who are treated and 100 placebo patients, and if you cannot detect that, there is no difference. And it's exactly what happened here. They add up more patients and suddenly it becomes significant P0001, but it has no meaning whatsoever. And I even think we should discuss the patients who were discontinued. There's no information exactly why. It was 18.8% as far as I remember in the Lecanemab study in the treated arm. There's no information why. Was it because of serious arrears? None of these have been examined afterwards. We have not heard what happened to these patients. And I would imagine that they have been seriously injured. And it should be controlled.
Does anyone know where that information may be hidden or not published? Or, I mean, is it available to Freedom of Information? Or
they can look at the MRI images, must be there. And so they can look at brain volume loss, but they cannot, it's too late to make FDG scans, which is otherwise the way they should do it, if they could have a comparable treated group and then comparable placebo group, but I think it's too late.
Well, I would also just add that, you know, it's not clear what information the FDA has. The company gives FDA aggregate information, gives them certain information. They don't give them everything. And the FDA can request it. But if the FDA hasn't requested it prior to approval, I don't know if they can get it later. And under Freedom of Information Act, you can only get something from the government. You can't get it from the company. And by the way, Freedom of Information Act, you know, it can take years to get the information that you request. But if the FDA doesn't have it to begin with, it can take years for them to tell you, oh, we don't have that.
Yes. And even if you get it, it would take a long time to analyze this in an independent laboratory where you're sure that the data you get are really right, will take. So that's why we advise all future studies should be with FDG PET MRI in all patients.
So let me throw out this question then. I'm just kind of looking down at the list. So what are the implications of offering Lecanemab to populations that are not included in the clinical trial? Should it not be offered to these populations?
I think the big issue with these other populations, especially African Americans and some Hispanics, is the comorbidities. That's probably why they were not well represented in the study, because they looked for patients with a minimum amount of comorbidities. And if you add this together with the increased number of strokes that are in the African American community and some others, it's likely there will be more side effects, more deleterious. But I'm not advocating that the drug is restricted from any group, but it is definitely a concern that it may have a more negative impact.
Sure. It increases the risk factors for certain, you know, subpopulations, so to speak.
Correct, likely.
And and the same thing happened with Aduhelm, where there were very, very few Blacks in the study, and yet the pressure to have Medicare pay for it was, well, you don't want to just, you know, you don't want to limit it to clinical trials in that case, because people of color would be less likely to participate, but they were never in the study to begin with. So it is a problem with the registry that's been planned for Lecanemab. If it gets full approval, there will be less discrimination in terms of access on a registry and the ability to collect more information, but then you have no control group. That's another problem, different kind of problem.
So here's a question I'll throw out to the panelists, and you can, one or all of you can jump in. It says, the quote, diehard amyloid hypothesis has misguided Alzheimer's dementia research, drug development, and clinical trials for 30 years. This could not have happened by chance. What do you think have been the reasons? Is there like a conspiracy theory?
Can I just
think-
say? Can I just say that I have,
Yeah,
I've had my hand up for a while here. I don't, you know, that gets into sort of the polemic, which I try to stay out of. But if you just look, I just wanted to point out that the question of causality that Dean Perry mentioned, you know, does the amyloid travel with the disease process or does it drive the disease process? A critical distinction. I would say that question is answered. You know, we've had the active vaccine trial that took away amyloid and no clinical benefit. Here we have, in my opinion, we have some taking away of amyloid, and the best we can get is a possible decline in the rate of deterioration that can't be sensed and might be, again, a statistical artifact. So I think the causality piece has been answered, but one thing to watch out for now is this hand waving about polypathology. Okay, you're going to hear that term a lot out there as a way of rationalizing negative results. They'll say, well, you know, amyloid is one piece of it, but then you have TDP, and then you have tau, and you have synuclein, and so if we just attack all these different pathologies, you know, we'll sort of you know, get to a meaningful result. So that's I think a little bit post hoc kind of rationalization. But I just want to say the causality question has been answered. As to why, you know, I think that I thought maybe Dean Perry would be better suited to answer that question.
So we'll put him on the spot.
You know, why has this idea persisted? A lot of very smart, well-placed people have argued for the amyloid approach. And the simplistic view, when the mutations were shown to be linked to the disease, it was one possibility, was that was driving the disease. We've now tested it. Animal studies do not test it because you create the problem and you remove it. So the transgenic studies we can just dismiss, except for the small biological questions that are being asked. And when you come to the human studies, you can't dismiss the importance of amyloid because of the genetics. It clearly plays some critical role, but that does not mean causality. It's some type of association with the pathway. The other part, which Dr. Castellani and I have discussed many times, is I think there's a real problem of understanding chronic diseases in general. You have the body responds to the aging process by producing many changes, and those changes are not always deleterious. They're part of what keeps us normal to 100 years. And trying to remove the polypathology, whether it's tau, whether it's all these other proteins, which we do research which shows that they play a critical role in oxidative stress and mitochondrial metabolism. And it's too simplistic to say that we'll remove the ugly wrinkles and do the plastic surgery and reverse the disease. As we get older, our body compensates, and that's critical in keeping us normal. And if you look at it, what's been promised is a cure for Alzheimer's disease. And to my understanding, there's no cure for any chronic age-related disease. There's only a change in treatment. And I think that's hindered the Alzheimer field for years. By trying to work for a cure, we've actually have no therapy. And I would say Aricept is borderline, but these new drugs are below borderline and put people at tremendous risk.
Thank you.
I have a question. I'm sorry. I have a question for other people on the panel. And I know you want to open this up to the audience as well, but my question for others on the panel is that that the data that has been provided by the company show atrophy, and they show, all these different variables, but they don't look at the relationship between the variables. They don't look at the relationship between taking the drug and atrophy, or taking the drug with certain genetic mutations and atrophy, or ARIA and atrophy. So shouldn't they have looked at that? And is that something that could be meaningful?
You know, I'd like to, from the very first trial, which Dr. Castellani mentioned, the shrunken brain was there. And I told him it was like the jungle ride in Disneyland where they brought two brains out, you know, shrunken heads, and said it was clearly a good trade for your intact one. They never said this was good. They said that the shrinking was because the amyloid was removed. Amyloid, if you've ever isolated it from the brain, is a really minor component. There's no way that that accounts for the removal of so much brain tissue. As Paul has pointed out, there's a tremendous amount of white matter changes, which is not even where plaques are. There's a tremendous amount of destruction because of inflammation, as Dr. Castellani has shown. And none of the companies have talked about this is brain destruction.
May I add to that it was really an issue when the first vaccines came on and then people, against what they expected, found out that there was a brain shrinkage, and they had expected the opposite. And since then, with the passive immunotherapy drugs, it has been downplayed all the time. It's maybe mentioned on the last page or in the supplementary material, and nobody really comments on that. And it is exactly right what you say. All the calculations of how is the volume of amyloid, even in very sick people, cannot account for that at all. So if there is only a very, very limited clinical effect, or maybe not even one of significance, then we should look for the risks. And in my view, this is so downplayed. The areas which I think is severe antibody-antigen reactions, when the edema part resolves with MRI, nobody speaks about it anymore. Nobody knows what happens with the neurons. So why not examine that before you even start giving it to patients? What happens to the brain of the treated patients?
But
nobody knows.
You know, we're discussing all of these shortfalls. If you go to the ELS Forum, which are basically the consensus of leaders in the field, the dominant people, they've already congratulated themselves that this is a major success. I listened to the news last night on PBS, the national government network in the United States, and the director of the NIA, National Institutes of Aging, said this was a major breakthrough.
So, you know, I guess I'll follow up a little bit with that kind of started us on this discussion. There are a lot of very intelligent people, scientists, doing research, you know, obviously the whole panel, I would put in that category. So how can it be that, you know, it isn't science, or maybe I'm just naive, because I remember science being something that is built on evidence, right? And if the evidence keeps falling or going away, et cetera, and you keep disproving aspects of a hypothesis, then, you know, why are we at this point? I mean, well, maybe it's not explainable. I mean, I don't know.
I think there is a junta who is governing this. I think it's so strange that the definitions of Alzheimer's is now almost without any clinical assessment. It's based on biomarkers, the quality, accuracy of which is unknown. It's incredible. You forget about clinical evaluation in these patients. And if this kind of biomarker diagnostics is used also to estimate how many Alzheimer patients are in the US, I guess they're probably not the 6.7 million, but maybe half. But that's another point. But there's something completely wrong with the definition of Alzheimer's disease. And we have to look for, in my view, events which will cause the disease to begin. And I think very much that the vascular aspect is all important, really.
So let's move a little bit away from the specific science. I know a lot of the attendees, of people who register, they were quite concerned about what to do about whether they should take the drug or not. So one of the questions here is very simple. It says, what is the best evidence to give to patients and their families, given the pending full approval? Yes?
I mean, I could take a stab at that. Just in that, I think we shouldn't fool ourselves that it's not going to reverse anything, and there's going to be no sense that that individual patient experiences any difference. And I would reiterate what I said before, was that in terms of who's going to suffer toxicity or not is unpredictable. You can get some idea, some insight based on ApoE genotype or based on imaging, but it by no means gets you an all or nothing. So there's an unpredictable nature to the toxicity of this. And I just wanted to, I wanted to get in while I can, because I think time is limited. I think I think there are serious ethical questions here that are unanswered. You hear a lot of rhetoric about, this treatment similar to chemotherapy. We have to accept a level of toxicity and even death to achieve the greater good. Is that applicable here or not? Is it on an ethical level? Is it okay that if we're going to make the drug widely available to thousands of people, even if 1% suffer a fatal complication, that's going to be a large number of people. Is that acceptable, and who decides that? Now, that's kind of the question I had. But anyway.
Also, to add to what Dr. Castellani said, as opposed to cancer, where you give these type of chemotherapy agents, usually they're later in the course of the disease. Here you have this woman that was out sailing the week before she died.
Yeah.
And most in the Biogen studies, many of the people are MCI, mild cognitive impairment, or even earlier with amyloid levels. Those are people that, if they were not treated, would probably have 5+ years, even if they developed the disease. And many MCI patients never progress to Alzheimer's disease. So you're putting people that have actually quite a long life to risk of death with what to gain.
Yeah, and so, some people, I would add to that, have lots of vascular amyloid and no plaque pathology too, and we don't really know who those people are either. So I really think the vascular piece has not been given its full due here. With all due respect to the drug companies, there are some details related to the neurovascular toxicity that are just being glossed over, and it's kind of shocking, really.
One thing I would just want patients and doctors to realize is that even if a patient has amyloid plaque, that doesn't mean they're inevitably going to end up with moderate or severe Alzheimer's. There's a correlation, but not everybody who has the plaque ends up with cognitive dysfunction. And I don't think people understand that. I think they think, oh, if they have this, it's an inevitable issue, and it's only a matter of time. And that makes people frightened and feel like treatment is urgent, even if the treatment isn't proven to work.
One more question that I have that I think perhaps our audience, we can go a little bit over time. Are there any promising therapies on the horizon in terms of drug therapy?
No.
Not that anyone knows of. Maybe I'll just switch gears a little bit. How about alternative therapies? In other words, in your collective experience, are there things that one can do as we age to decrease the risks of dementia?
There's been a tremendous amount of progress on this. that, in fact, it could be distilled to 4 points: stress reduction, exercise, diet, and social interaction, having a meaning for life. And probably, though it's not proven, is probably different, responsible for the difference between different social groups and incidents, probably driven. But that's not what people want to hear. They want to hear a pill or an infusion. This is something about changing your whole life, and there have been several advocates and reasonably good evidence, and some of it with random controlled. The Finnish study is probably the most notable.
So basically, you're saying the usual suspects.
Well, and I would add, I had mentioned before, I think before anybody considers taking this drug, the first thing they should do is look at the side effects of the drugs they're already on, because there are a lot of older people who are on anti-anxiety medication, opioids, and also on allergy pills. And all of these things can have quite an impact on the ability to concentrate and remember.
I'm skimming through real quickly some of the questions from our audience. Some of them a lot of them you've already touched on. What about the previously approved, I guess you would call them conventional drugs, like donepezil, memantine, etc. Do they have any kind of efficacy at all?
It's of the same size. I've looked a lot upon it. It's of the same size, and if there is any, it's a little bit larger than with the passive immunotherapy, which is close to zero. There is a Cochrane analysis of one of them, and that's negative. But it's a very, very large job to examine that in detail. But no, it's almost, conventional therapy is almost not effective either. It has a lot of side effects. So should you choose or use the uncle test, I have a wife who is seriously ill from that. Would you give her a drug with serious side effects, which make her anxious, which makes her give her a headache, which makes her vomiting? No. So I would never give that to anybody I like or love, any of this kind of therapy. And it's an advantage to prolong this process. It's not moral. Most people don't think we should talk about it. I would say no.
And along the same line, I wish Peter Whitehouse had participated. He knows more of the history than I do about the approval of these drugs. And there was, again, the same push with the limited efficacy, because they said that we don't have anything else, and they offer hope. I didn't know the drug industry was about hope. I thought it was about efficacy and safety. So we've exchanged what my understanding of what the FDA is supposed to protect us from. I mean, hope is for religion, inner self, and spirituality. It's not about a bottle.
Understood. So I guess to wrap up a little bit, there appears to be a lot of disadvantages to the FDA's pending full approval of Lecanemab, like on or prior to July 7th. I mean, obviously, we'll have to wait and see, but I would say that if I was a betting person, that's going to happen. For patients and caregivers of Alzheimer's dementia, it seems to be that there is no effective therapy after onset. And so the best we can do, and it's probably a good thing to do anyway, is the usual suspects. That is, exercise, diet, remain active, do a lot of reading, go outdoors, you know, do stuff that makes you feel good and human. And that's what we have at this point. Is there kind of a consensus on that?
Yes.
Yeah, I would just add the physical exercises seem to be a little bit more effective than the mental exercises, exactly the opposite of what we think. I'd add, you know, maybe a pet. You know, people need social interaction, and if they don't have it with people, then they can get a lot of support from a pet, and depression does seem to have, you know, a negative impact on cognition. So.
Well, I have a cat and a dog, and I know that they're both shelter animals, and so we should all run to the nearest shelter and grab a few pets because they need homes too. So that's my plug for homeless.
Can I just also mention that the anecdotal case that I mentioned was an individual who had a lot of pathology when we came to examine her brain, a lot, basically advanced Alzheimer's disease, but was actually functional. And this is a person who was very physically active, exercised a lot, very read, worked, engaged, and so there is a level of resilience that one can look at in terms of some of these lifestyle factors. So I think the points that were raised, I think, were very apropos.
Okay, great. Any final words from our panelists before we sign off? Right, then I would like to first thank Les for hosting, the webinar. I think I would also like to thank each and every one of you panelists. You've been great, very people that I would like to get to know better and have contact with in the future. One of the things that we had talked about at AAIS, Alzheimer's International Society, was to not make this a one and done situation, that we would like to perhaps do a webinar very much like this one every few months or every month and a half, et cetera, to kind of continue the dialogue on a very important topic, and that is the treatment of Alzheimer's and dementia. That I certainly have a stake in it because I'm an old guy and getting older by the minute, and I could use all the help I can get, whether it's from the pharmaceutical industry or from just living my own life, exercise, eat well, and all that kind of stuff. So once again, thank you all, and we'll be in touch.
Thank you.
Thank you.
Thank you.